So the idea basically is to have a conversation and be a panel issue around some ethical issues and the regulatory intersect between, in terms of adolescent research. And I think we're quite fortunate within our faculties. We've got quite a strong emphasis on adolescent research, especially from the Gail Becker's unit, which is very important. And the reason I say that is that you'll see some of the discussion around some of the slides is that part of the responsibility of the ethics committee is not only to look after the participants, but also to understand where participants are coming from, what their needs are, their requirements, and how do we actually actively protect those. Without actually understanding the needs of the adolescents and having the collaborative discussions with our investigators and maybe sometimes the community, it makes it very hard for ethics committees to actually make these decisions. And I want to leave you with that because I think it's a very important issue. Collaboration is very important to understand the population that we're actually dealing with. So just to say, and this does work, so maybe not so well, but basically what this is showing is that the reduction in HIV expression in children, in young children, is occurring much faster than what's occurring basically in adolescents and the older population. And for us, that's very, very, very important in terms of our research agenda and how we look after the health of this population. And just in terms of some of the stats, and as I suggested, we have to empower ourselves to actually understand the population that we're recruiting. We want to make sure that the science is valid and that the ethical issues are valid in terms of what the risks are to that population. Because you want to balance out the risk-benefit, and you then obviously need to understand what is actually occurring in that population. So as you know, it's the leading cause of death in reproductive age. Women are disproportionately affected in sub-Saharan Africa, which accounts for about 60% of infections. And globally, the age group is around 15 to 24, and we'll say something about the age group again a little bit later on when I look at the regulatory issues. Women get doubly have the risk of infection than men, and approximately there's 1/4 of all new infections are occurring especially in women. So the considerations for public health, and I'm talking about public health in general, because public health will require some service orientation but also research to conclude that we operationalize our public health initiatives appropriately. So the idea basically is to invest into this population, and I'm just looking at HIV as an instance. You could talk about diabetes if you wanted to, and then obviously define the local context specific characteristics of the adolescent populations which are at risk. So to actually define what one is looking at, and then obviously for the research agenda to develop protocols specifically for that. For me, vulnerability is very important, and what's highlighted and what should be highlighted is that when populations are vulnerable, we add a layer of protection for vulnerable populations. And adolescents fall into this group of vulnerable populations, and it includes key populations living with HIV. And some of the issues are because they're at risk of stigmatization, the backlashes that occur within the communities, as well as they're not always in control of their sexual and reproductive rights. For example, forced sterilization, which may occur. We need to understand these because we need to understand what may occur, what the risks of enrolling young adolescents into research, what may be the fallout for them if they are enrolled into research, and obviously they're disadvantaged in terms of negotiating safe sex. And I've added some of the vulnerable populations: drug users, transgender populations, sex workers, students. People can't believe at the institution students are massively vulnerable. We do a lot of research into students at a high risk. So I'm just going to look at a little bit of gender inequality. It's a very busy slide, so and these slides are freely available to you. But the issues around access to healthcare, access to safety when the gender inequality is very problematic. So what do we know? That when individuals do not conform to gender norms, they face huge amounts of stigma and huge amounts of discriminatory practices or social exclusion, all of which will negatively impact their health and health access, as well as impacting their recruitment into clinical studies or into whatever studies there are. And we need to make sure that we add a layer of protection for this group. And the layer of protection doesn't mean we obstruct the research And I think that's very important. It can be seen to be, well, you become overly anal and retentive about actually protecting, and you actually then don't do anything. That's not the idea, and that's why collaboration is actually very important, to make sure we actually understand what the risks are, because one can overreact. Very easy to overreact and to add too much protection. But the idea is to collaborate. What is the actual risk, and are we mission creeping in terms of preventing the recruitment of this population? And then they become under-researched, which is then an ethical problem. So some of the social, cultural factors which influencing adolescent sexual and reproductive health in Africa, the values of fertility, the age of sexual debut is much younger at this moment in time, especially in South Africa, where the age is around 9 years old at this moment in time. In some of the studies that we've looked at, the age of first pregnancy is a problem. The virgin myth, which is unfortunately still a problem in our country. Forced marriages are still occurring. The stigma of childless, and then transactional sex. And then I have this wonderful image which I stole from Linda Gale Becker. So I said courtesy of, which actually means she actually agreed to it. She didn't. So can I use it? Thanks. I just thought it's absolutely wonderful, this diagram in terms of what is occurring in our population, how transactional sex occurs, and what the risks are to the various ages, and how the perpetuation of the disease process is wonderful. It's easy to understand, and easy for us as an ethics committee to understand why the populations require this research and to be enrolled. The teenage mouse, I can totally get away with this. I've got kids of 13 and 16, gosh, okay? So there's nothing they won't do, okay? And that's the problem. I can leave you with that. There's nothing that they won't do, and we need to just understand that. And if we understand that, we can build in protection and allow people to be able to be involved, maybe with a bit of guidance in terms of what they require, rather than tie them up that they don't do anything, because there's no learning, and once again we don't get any answers that we require. So the idea basically is not that we understand that and stop anything. It's about how do we work with that. It's like patients who smoke, patients who overeat, etc. We've got to work within that environment. We can't stop people from doing what they're doing. So it's a mission creep. So this is the intersection of social determinants of health, cultural factors, and gender inequality. And all of these, for me, play a major role. And we have to understand all of these influences in terms of the protocols that we review, where recruitment occurs, how we look at informed consent, and how we look at parental consent may or may not be required going forward, and how we make sure that the research agenda isn't disimpacted by what we do. It's actually empowered and facilitated going forward. So it's important that this population, the experience of discrimination, health risks, and lack of access to resources needed for health attainment are compounded by all these social determinants. And we must understand that while we are reviewing protocols and where participants are coming from. And the ethical awareness and halted viability is essential. Again, not to obstruct, just to make sure that we are protecting the population appropriately. And what is the impact of research on adolescents in health? And importantly, what is the role of the RECs? So what is our role in all of these? Well, the issue is, are we just a band-aid? Okay, the superpower that actually, we're not actually the superpower that has a role. It's a collaborative role. It's absolutely everybody's responsibility. It's our job to empower ourselves and to learn from everybody else to be able to get this right, so we can make sure that we recruit appropriately with good, strong, well-justified protocols. And the idea basically is the question, it's a good question to ask, how can RECs fulfill ethical duties and responsibilities to protect the study participants and improve their health outcomes? It's easy to protect. It's not easy to do the second one, which is actually to allow the research to occur, so we maybe get answers that improve health outcomes for this group. And basically there's a growing need to ensure that the structural drivers of HIV, and especially sexual health, are addressed in ethical reviews of adolescent health research. So we ask the investigators to provide us with as much data as possible for us to be able to make our risk-benefit decisions. So this is I was asked to speak around the regulations and which impact. Okay, and what I'm going to show you, there's a disconnect between the ethical guidance and some of the regulations. And I'm only going to talk for South Africa, and I'm very sorry, but I think that you probably find there's overlap in other countries as well. So if you look at the section 7/2 of the Constitution of South Africa, it says research should promote and protect the constitutional rights of adolescents in research. It actually says that. Then the next is the South African common law, which says research should not be against public policy, includes values of human dignity, equality, and non-sexism. All very good. And then research should be in the best interest of the child. Significant research risks contrary to the best interest principles. So it's very easy to just say that nothing's in the best interest of the child, and you never have to approve anything. So the question is, you've got to understand what is actually in the best interest, because my best interest may be completely different to in somebody else's best interest. And it's a very vague, loosely used word, what is the best interest? And it's a very good idea to collaborate on that, so we don't disempower. Then, thank you to Luga. I was given this a couple of days ago, where Anne Strode and Catherine Slack, they looked critically at the waiver, for example, of parental consent and the law and ethics and how there's an impact on ethics committees. And are we breaking the law when we actually allow a waiver of informed consent? We don't get parental consent or legal guardian consent. We've been there for a very long time with the guys that we're doing a good thing. Yep, with the guys we're doing a good thing, and that ethics trumps the law. Okay. But I thought I'd just put this into perspective. So here's some of the issues, okay? Section 71 of the National Health Act says requires mandatory parental consent for child research and limits authority for proxy consent to parents or legal guardians. That's what the law says. Okay. When you look at the Department of Health Act, the National Health Act of 2003, it says authorized national ethics guidelines. So it actually authorizes the Department of Health's National Health Research Ethics Guidelines. It's given credibility to those. Allows a more nuanced approach to consent to child research. Includes self-consent by older adolescents, provides strict conditions are met. So there's a complete disconnect between what the law says and what the nuanced approach is from the Department of Health guidelines. Okay? So this places ethics committees in a bit of a tight spot, an invidious position when approving child consent approaches that are inconsistent with Section 71 of the law, but they are consistent with the national and international ethics guidelines. So we are accredited by the national ethics guidelines, yet we are maybe trumped by what the law says, and how the two aren't meeting. So we've got to find a way to actually overcome that. The other is the Section 71 defines therapeutic and non-therapeutic research. Non-therapeutic research must not pose more than significant risk, and significant risk defined as substantial risk of serious harm. Still not sure what that is. And then the national guidelines say it refers to minimal risk conditions. And so we need for development of clearer risk standard in law that is consistent with national and international ethics guidelines. So the lawyers and the ethics committees and the representatives have to get together and say that how do we get common ground so that we can allow research to occur in a way that's not obstructive. And please give the research ethics committees the responsibility to take care of the vulnerable participants, because we have a guiding body. Okay. The other act is the mandatory reporting of physical abuse causing injury, etc. There's a mandatory to actually report, and unlawful sexual activity. Okay. Where the National Health Act and the Children's Act and Termination of Pregnancy Act and Child Justice Act says potential for unintended consequences of increased harm, physical and social for adolescents. If you report, this could happen. You could actually get much more violence and much more harm can actually occur. And thoughtless reporting may violate privacy and confidential interests of the adolescent. The one and report what you may cause this harm, and how do you find common ground for that? So again, there's a potential ethical dilemmas presented by the rigid legal mandatory reporting requirements versus, in my opinion, a more nuanced ethical approach is in fact required, so we don't get caught up by legal requirements, and again, we then disempower the research agenda. Okay? And just remember, reporting alone does not absolve from ethical responsibilities, and arrangements must be made to assist the effective adults. That's always the issue. We just report and then it's not our problem anymore. That's not true. It is your problem, and so one has to take it forward. Okay. So some proposed ways of going forward. So in instant, we need a uniform definition of the age of adolescence. The DOH guidelines is 12 to 17 versus the 10 to 19 of the United Nations. So there's a discrepancy, and we can decide which one we use. We need to network between RSCs to promote standards for ethical adolescent health research. I think it's very confusing in our own country is when the different ethics committees do different things. And it becomes very confusing when you've got multi-center studies. And I do think we need to get together on some very in principle, and we all say the same thing, because gosh, why are we thinking differently? There's a problem. And the generation of ethics repositories of material to support all stakeholders. We should have a library of what data we've used, our IP, what we've used, we change it, and it's transparent in terms of what we use to make our decisions. And so further regulatory and policy reforms needed to facilitate research involving adolescents. We need to sit down with the legislators as well, legal people as well. And we need a need for clear ethical guidelines that take into account complex intersections between the nature of research, age-related factors, social determinants of health, cultural factors, and gender inequality that influence adolescent vulnerability. We've got to find a way to actually get clear guidelines that deals with this population. Otherwise, we're floundering. Just to bring you back to what makes research ethical, this is Ezekiel Manual. It's a brilliant document from 2004. People will have seen this. It's Manual 8. We use this on our ethics committee to review all our protocols, the way it all intersects in terms of our ethical review. We try and tick all the boxes if possible. If not, people should just justify why not. Okay. And the question is, for adolescent studies, what are the ethical considerations beyond the Manual 8? It's easy just to have the Manual 8. Well, for me, it's using moral imagination to consider foreseeable risks of harm to adolescent participants. And what that means is to think ethically out the box, okay, to be able to look at the ethical issues, but also to look at the outcome success. Otherwise, we just look at the ethical issues and we negate the outcome success, which is a real problem. Post-child care and ancillary care are both essential ethical considerations in the adolescents and should be fought hard for by investigators. And then, can the scope of the manual framework reasonably broadened to include an ethical obligation to address structural inequalities? That's quite hard. I'm asking investigators to work quite hard here, and maybe that's much more difficult. Maybe there's another collaborative mechanism to scrum down together to deal with the structural inequalities that have occurred. What about informed consent and social processes? Well, higher congruence between researchers and participants is the greater likelihood of good consent conditions. Okay, that means you have to look at the cultural beliefs, structural factors, and language to make sure we're getting proper consent. Greater dissonance, less likely to achieve consent conditions, and the goal is to develop strategies to diminish dissonance. So we actually are comfortable that there's a good consent process, and it's always an ongoing process. Okay. So adolescent independent consent, which is obviously, I would presume, very important for this group. It may be very desirable and ethically justifiable for minors to choose independently, that is without parental assistance, whether to participate in research. It may be very important. Examples include discussions about sexual activity, substance abuse, etc., where people don't want their parents to know and will clam up and will not become research participants and give us the data we require. Generally appropriate for adolescents 16 years and older, but may be justifiable in a younger age if they are cognitively okay to actually do that. And we're often guided by the investigator who can give us that assurance, and usually minimal risk research. Okay. The adolescent independent consent, reasons for independent adolescent consent include difficulty to recruit, because people will not recruit if their parents or guardians have to give a consent for them to be approached. And the requirement for parental consent may in fact lead to increased harm for that. That could be the perpetrators. Maybe it is increased harm to the adolescent. Just to say a few words about, firstly, a minor in our country is less than 18. People still think it's 21. It's less than 18, and that's quite important, because if you're doing research on 17-year-olds and they reach the age of majority, you have to reconsent them. The other issue is around the mothers. People believe in our society that you become a major if you're pregnant and have a child. That's not true. Okay, that's not true in our society. The mother of the child or the father of the child or legal guardian still has to give consent for her and her child to be into consent. So there's a cultural issue that one needs to look at. So it doesn't change your legal status, but marriage does. And then what about orphans and... Sorry, I should have been further away from the door. So what about orphans and vulnerable children without guardians and research participants? Well, I think you never want to have a left-out population. It may be very important to do the research in this group. So it's easy to just say, well, you have no parent guardian, so you're excluded. You've got to find ways to actually do that. Thank you. And the idea basically is that if it's ethically justified to include this population, then we need to find a way to actually include the population and find other proxies or people that can actually give research. And so here's my pragmatic approach to doing that, okay, for orphans and for vulnerable children. If no parent, the guardian either court-appointed or is indicated by the parent in a will. If there's no guardian, then foster parent per order of Children's Court. If there's none of that, then maybe a caregiver is defined as the Children's Act. And if a minor is in a caregiver in a child-headed household and no supervisory adult, then trusted adult nominated by the minor, e.g. social worker, community worker, or teacher. And I've just tried to find a guidance so that we actually get beyond it and we may be able to actually recruit adolescents. And this is what I thought my summary of ethical considerations for adolescents. The broad-based social considerations versus the individual considerations. Thank you very much for inviting me to talk.